there, but often if you go to a lion's park, you won't see lion, but lion is there and lion is always dangerous. It can kill you and it can injure you. So always we should be careful about DVT in our patients, the intraoperative or postoperative or other patients. So first thing I identify is whether the DVT is unprovoked or provoked. That decides how to treat and how to follow up these patients. If it's a provoked DVT by trauma or bed rest or tight dressings, we need treatment only for a short time. But if it's an unprovoked DVT, we should be careful about it. A detailed history is very important. You have to look for any pre-history of thrombosis or family history or embolic history or any vascular disease like myocardial infarction, stroke, etc., which may indicate thrombotic conditions. So what happens is all quite obvious. Any vascular surgeon who treats DVT should know how to do the Doppler, and Doppler is always diagnostic. Look at the deep veins for non-compression, non-augmentation, and non-phasic variation on valsalva or deep inspiration, and always try to identify which segment is involved in this patient. Here also you can see that this artery is non-compressible and vein is compressible. The normal vein should be compressible. It is non-compressible, that's the status of DVT. And exam abdomen is very important, particularly in patients with bilateral DVT, and investigation into mainly to identify as a thrombotic, the patient thrombotic one or a non-thrombotic. So thrombotic may be identified with various tests are available. The huge battery of tests are available, but I do at least 5 or 6 cases in all these patients like homocysteine, protein C proteins, or antithrombin, factor V or APLA. At least these tests should be identified in all patients. 30 to 40% of thrombotics can be identified, but still some people can miss the list. And D-dimer. In all patients with DVT, acute DVT, you should look for the D-dimer test because that will give an idea about the risk of embolism. As the volume or value of D-dimer goes up, that means the huge volume of thrombus is there, there's a chance of embolism is there. And in rare cases where you're suspecting DVT and Doppler is not conclusive, you can look for D-dimer for high values, particularly if not a post-operative patient. And D-dimer is important to follow up the patient whether the treatment is adequate or not. One question is, the most important thing is the thrombosis DVT sometimes indicate an underlying malignancy. The ample study shows that the DVT indicates a pre-sample sign of malignancy which may present during the first attack itself or when you follow the patient for at least a year. So there are a lot of studies, but the most important study was Thomas study. And in fact, it identified that 10 to 15% of patients with the present DVT can have a malignancy. And if you follow this patient for 1 year, the chance may go up because some malignancy will come later. So there is Swedish data which has the largest data on this aspect, and this is overall incidence of malignancy in a patient without any symptom or signs of malignancy. Present DVT is about 15%. That's a huge number. So all vascular surgeons treating DVT should look for and should think for an underlying malignancy. So if you look at the comparison of malignancy in the acute presentation and the 1 year follow-up, again there's a huge difference between these two classes. There is an incidence between 7%, 10% difference when you follow up this patient. So all DVT patients on treatment should be followed for 1 year looking for malignancy. That's also important. Particularly these patients because more than 70 years or they have a chronic lung disease or there's a thrombocytosis or anemia, we have to think about investigate the patient for malignancy. Why do we treat this patient? One thing is, as you have seen that patients have a lot of local problems like edema, swelling and all those things. And they have a chance of pulmonary embolism which is discussed earlier by Dr. Perry. And there's instance of post-thrombotic syndrome which is a long-standing complication with a lot of ulcers and patient may be having a lot of mobility. Because of these 3 problems, these patients has to be treated properly. Treatment is always, there are many options available because time comes I'm not going to thrombectomy and thrombolysis which is the ideal treatment for this condition. But all the patients with DVT has to be embolized immediately, particularly if they have a high D-dimer value or they have a ileocameral involvement. Then the patient is embolized to avoid embolism. Anticoagulants and thrombolysis are the treatment of choice and when to treat is immediately after diagnosis. If you diagnose DVT, the patient should be advocated or treatment, where should be discussed about treatment, and heparin should be started immediately if no other choice available. So treatment should not be delayed for any acute DVT. We have multiple weapons for treatment. The most important is heparin, the time-tested one, the conventional, which has very few complications can be given to any patients, pregnant or non-pregnant, lactating or any patient with any disease, we can be heparin and regular antidotes are available. The problems are very short acting, lasts only for a few hours. frequent dosing is required and it can lead to morbidity, but it can be controlled with antidotes. Global heparin is compared to safer options, which is costlier. Daily injections are required for the patient and some are long-acting, but antidotes are still available. And this I asked Dr. Patel in the morning, it's ideal for pregnancy and lactating ladies. It is the ideal one for long malignancies, prophylaxis, particularly GA malignancies, and it's patient convenient if they can afford to do it. And suitable for bridge therapy also. Third one is warfarin, the conventional traditional medicine. It is tested in a number of patients. It can be safe in pregnancy, but some controversies. But the thing is, it's very difficult to control if it bleeds, and then you need to you have to do a frequent PTANR to identify which dose is adequate for this patient. And the WAF is notorious having interactions with many food and drug. Then you have a newer anticoagulants. The advantage is there are fixed doses. You don't have to change the dose according to that PTANR values. The thing is, no monitoring is required. We assume that it has adequate action with very few interactions. The problem is, still there are no effective, cheaper antidotes available, even though some are available. Again, its cost is a factor, and patient renal disease and GA disease, we should be careful about it. So agents are basically dabigatran, a direct thrombin inhibitor, can give 150 mg twice a day, or Voroxaban, which is most commonly used and mostly the most patient-friendly thing. It's a factor Xa inhibitor which has less renal clearance and mostly liver clearance there. Apixaban is a factor Xa inhibitor. It is ideal for steroid. How to select this? Patient with dyspepsia, better go for Apixaban. Instead of GA bleeding, still ideal one is long heparin, or you can go for Apixaban. Or if the patient is elderly, can go about renal function problems, can go for Apixaban. So how to follow up these patients? In fact, no follow-up is required. We can give a fixed dose and patient may have adequate. But if you want to do it, you can go for a PTT or a PT. PT is not recommended, or you can go for anti-bacterial doses. Antidotes are available, but the problem is it's not so effective and it's not so easily available. It's costed also. Desmopressin or agents, hemodialysis can be done, APCs can be done, but still they are not really available. So the thing is, when do we, when surgeons, when you treat this patient, you know when to stop this patient medicines when you are planning for elective surgery. If you are planning for minor surgery, you have to stop 2 days before the procedure and convert if required, convert to heparin. And you can 3 days if the renal function is compromised. So when you start after procedure, if it's a minor procedure, patient can be taken afterwards and you can take the static tablets after 24 hours of the procedure. If it's a major procedure, stop 3 days before the surgery and restart it 2 days after the surgery. So the question is how to bridge it. In fact, in most of the surgeries, most of the procedures, you can continue with VAS, but sometimes you have to do it LMWH. If a patient is getting LMWH or patient is converted to LMWH, we can use either LMWH or VAS after the next dose of treatment. So why do we identify it's provoked and unprovoked? That's the most important part. If it's a provoked DVT, you have to treat the DVT for 3 months. If it's unprovoked one, the first episode you have to give treatment for 3 to 6 months for recurrent problem. If you identify any factor, so the message is very simple. DVT is very common and life-threatening. You have to identify all these patients, and it should consider the long-term implications. And always look for thrombotic pathways that may need lifelong treatment, and you have to identify the possibility of malignancy of this patient. And once you diagnose DVT, the treatment has to be started immediately. Identify the select drug, it's convenient to the patient, and dosing is very important. And all these patients require follow-up at least for a year for the underlying malignancy.